Hello and welcome to this Health Tech World Roundtable discussion, the latest in a series of roundtable discussions. And today we're going to focus on the ways in which artificial intelligence is transforming healthcare. So over the next 45 minutes to an hour, we'll talk a bit about where AI is improving health equality and accessibility. We'll talk about the risks and barriers, and we'll talk about the importance of collaboration, amongst other things. I'm delighted to say that we've got a really impressive group of panelists with us today who've agreed to share their insight with us. So I'm going to kick off our discussion by asking each of our panelists just to tell us a little bit about themselves, their organisations, and their areas of particular interest. If I could start with you, Afshin.
Thank you, and hello everyone. Afshin Attari. I'm the Director of Public Sector and Unified Platforms at Exponential-e. Exponential-e is a technology managed service partner, a sovereign UK company. We work with the whole market, and we have a vertical focus towards public sector. We try to deliver innovative technology solutions in the critical national infrastructure arena to support government. The healthcare vertical is our biggest vertical, and our aspiration is to ensure that we can de-risk deployment of technology and support the adoption of technology in delivering better patient outcomes. We hold 16% of the health and social care network, 20% of the platform market, and we are very keen to support the health service, but also government as a whole, as I said, not just health, central government, local government and education, in delivering the desired outcomes to support citizens and patients. Nice to meet you.
Great, good to see you again, Afshin, and thank you. Anushka, could I come to you next, please?
Of course. Thanks, Afshin, for your introduction. Very nice to meet everyone and great to be here. I'm Anushka. I have been in health insurance for the last 12 years for my sins, and prior to that was an practicing doctor. Currently, I'm Chief Clinical and Innovation Officer at a business called Cignpost. And Cignpost was born out of where we stand in health systems today. It's a new type of insurance made more accessible and affordable for all. That includes individuals and small, medium enterprises. And it is there to tackle the problem we see in our health system today, whereby NHS waiting lists are increasing. What we know is that the longer you wait, the less quicker you heal. And we know the poorer your health outcomes. For example, 80% of people are waiting more than a week in order to get a healthcare diagnosis, but we also know that 80% of people after a healthcare diagnosis don't actually need treatment. What Cignpost has done is built an insurance solution that focuses on that diagnostic element. It is a diagnostic insurance proposition. It is cheaper and more affordable than your traditional private medical insurance. And what it allows is accessibility to have your diagnostic tests, whether it be blood tests, scans, biopsies, or anything else that you might require in the private healthcare system, building a hybrid between public and private healthcare, and getting you the answers you need so you can heal faster, less worry, less wait, better peace of mind. I also have a background working in AI, advising the UN and the World Economic Forum on policy matters, and I'm excited to be here today to discuss some of those, including the challenges we're seeing today.
Great, thanks very much, Anushka. Sunil.
Well, thank you, Alastair, and it's great to actually share a panel with both Anushka and Afshin. I'm Sunil Daga. I'm a kidney specialist. I work in Leeds Teaching Hospital. I'm also a clinical associate professor, so a clinical academic, sort of double life between the university and the NHS. Today, I'm here in my role as Health Equity Lead with NIHR Health Technology Research Center. So the government has funded 6 HRC, and our remit really is to make the technology equitable, but also to allow the scalability, both scale and pace in real life world. So we work with a lot of industries, whether it's medical technology, AI, to actually ensure that it meets the need of NHS, the population we serve, and it's actually system ready, so it sort of fits in the clinical pathway, which is actually a real major challenge when the products are presented to us. So hopefully I'll be able to share some of that experience, Alastair.
Great, thanks very much, Sunil. And we'll definitely come back to a number of those themes, I'm certain, during the course of the discussion. Just before we open up that discussion, I'm keen to go around the panel once again and just ask each of our panelists a sort of kick-off question. Where is AI having the biggest impact at the moment? And again, we'll just start with you, Afshin, and go around in the same order, if that's okay.
From our perspective, we see a lot of potential around AI. If I were to cite clear examples, I think from a technology perspective, we're not seeing the benefits as such in healthcare, but we may be wrong. I think what we're seeing is the opportunity. And what we're doing is we are investing a lot of time in really providing the bedrock for AI to succeed. And what I mean around that is the premise of AI is around accurate and available data sets. So what we've been doing is, for example, Sunil, we've been working with the National Pathology Cooperative in providing a platform for digital pathology, which enables 28 hospitals to share and collaborate data in that perspective. So sharing that data in a secure, resilient manner will fundamentally support the ability to take a step further and utilize AI in that space. So in answer to your question, Alastair, I think there is immense potential, but what we need to do is we need to maybe manage some of the key risks and dependencies, which are seen to be restricting the use of AI, to make sure that we can accelerate that. So I think that planning and investment around collaboration will help accelerate delivery of AI, and undoubtedly it will deliver clear benefits around patient outcomes. That's our perspective.
Thanks, Afshin. And we'll come back to that question of risks and barriers to development. Anushka, your perspective on where AI is having the biggest impact?
Thanks, Alastair. I partly agree with Afshin. I think one of the biggest challenges with AI today is around data. The foundation of AI is built on structured or unstructured data, being able to see patterns, enrich the data, and make something meaningful out of it. And you can't train models if you don't have data in the right place. Data fluidity is a problem across health systems. You don't have a full, true longitudinal care record because it's fragmented. Wearables data, lifestyle data is not integrated with clinical data. Patient data, reported outcomes, etc., aren't necessarily always integrated with clinical data. As Ashwin alluded to, a lot of it is unstructured, and therefore being able to process it and make a story or tell a story out of it is difficult. And then obviously you can't then develop true AI. So I think we have a problem with developing the right kind of AI more broadly across healthcare. However, I do see pockets of very, very meaningful AI, whether that is in process optimization, whether that is in scribing, that have been embedded in clinical workflows. And I want to come back to that piece later on, how the importance of getting AI operating in healthcare environments is truly based on having buy-in across all stakeholders in the system, but having it embedded into the workflow so that it reduces friction rather than creates it. And we've seen that in certain aspects where AI scribes are now assisting doctors during their clinical work environments, whether it's ward rounds and or clinics, and then creating efficiencies and helping with clinical decision support as well. We've seen AI deployed in remote patient monitoring environments where, again, it acts as an assistant. So for me, it's not artificial intelligence, it's augmented intelligence. And then we've also seen AI in fields like my own, which was radiology, whereby because of the way radiologists work, images, and they look at patterns amongst images, businesses like Cure.ai have been able to build algorithms and be able to detect cancers, I would say, equally as effectively, if not more effectively, assisting, again, the clinician to be better optimized, either in making decisions or more effective or more efficient. So it has been developed, it has been deployed, it has been implemented. Where I see it is pockets rather than widespread, agreeing with Ashwin. I think one of the key challenges, apart from the data, is around trust. And that is trust from all stakeholders, including the patient, that this is acceptable and okay. And my biggest gripe is we compare AI when we deploy it, whether it was, the chess model and or otherwise, to being better than humans. And I believe that's the wrong place to be. It doesn't need to be better than a human. It needs to assist and embed and work alongside a human, particularly in healthcare. And once we build that trust, as I say, within society, within healthcare practitioners, but also within the patients, I think we have a huge amount to gain in the health space. Healthcare at the moment has, I think, if I'm not mistaken, around a 6 to 7% adoption of AI versus financial services, where it's more like 20%. And other industries like e-commerce, where they personalize your buying experiences, have it more at 30% mark. So we have a long way to go to catch up, and regulation and policy needs to come along us. But it is there. It is there, and it's making impact today amongst clinical environments and otherwise.
Thanks, Anushka. And it's good to see Josh has joined us. I'll come to Josh in a minute and ask him to introduce himself. But before I do that, Sunil, same question to you. Where is the impact? How do you see it?
Yeah, I think building on two of my other colleagues, I'm already seeing AI impacting the way I'm working, the way things are working. Maybe that's because it's in Leeds. That's because we are sort of in the forerunner for it, whether that's in the NPIC that Ashwin, you mentioned, whether that's radiology. Now when I go and look at X-ray, the AI is already sort of reading that for me before I even try and read that. I don't need that particularly, but I think we need to understand in the context of, the workforce, in context of the skills of the workforce, having repetitive tasks or having things that has good data or large sums of data that has been validated very well. For example, mammogram, the breast. For example, retinal screen for hundreds and thousands of patients with diabetes. For example, X-rays, we do so many thousands of them that goes through A&E. So in those fields, it is already making a very good impact in terms of patient safety netting, in terms of detecting that subtle changes that often the human eye may not necessarily detect. So I am seeing that impact already. Within my own kidney world, machine learning or artificial intelligence is not new. We had a AI algorithm. We didn't call it AI. It was like 40 years ago when we just set some algorithm based on, sort of support mechanism. Now, of course, the AI has become the buzzword and everything is linked to AI. So just to give an example, managing patients' hemoglobin, linking that with treatment decisions, which was a very repetitive task every month on hundreds of patients. That's now well taken care by a standardized algorithm, which my colleagues sort of published good 30, 40 years ago. The other example very recently we are working on is actually AI as a safety net, decision support for kidney transplant patient follow-up. Say an algorithm developed in Paris. We are doing a randomized control study, the best evidence you could have to show that it adds value compared to standard of care. And we are very lucky actually to test that in Leeds and within the UK. So what I see is there are things that are already embedded, but I totally agree. It depends on the system. It depends whether it's reach, as we say. I think the biggest challenge is really that scalability and that pace to benefit what we have. It certainly it can make a huge impact, and is making impact on select few centers, and much more can be done. Is what I feel, Alastair.
Thanks, Sunil. Good to have you with us, Josh. Josh, could you just say a few words about yourself, your organisation, and your areas of particular interest? And all the other panelists have just said a few words about where you think AI is having the greatest impact at the moment to set the scene.
Yeah, absolutely. So I'm Josh Miller. I'm the founder of a company called Gradient Health based in North Carolina in the States. So we solve the problem of AI companies need access to data to train. And so we work with about 70 different AI builders within the healthcare space, providing them the data from hospital systems that they need to build a product that's equitable. So good examples of what's been built on our data is it's mostly radiology data. So everything from cancer detection, hemorrhage detection, automated contrast enhancement has been done on our data. As far as where I see AI going, I have to say I agree with Dr. Patchava. Augmenting the physicians is really where it goes. It doesn't end up being a replacement. There are certain scenarios which I find very interesting. A good example would be contrast agents. Where we're not talking about enhancing a physician, we're actually talking about changing the way medicine is done rather than making it faster, more efficient. In contrast agents, for example, you can lower the dosage of the contrast that gets given to a patient and have an AI do the rest of the enhancement. So if you look at a contrast CT versus a non-contrast CT, we can create a small difference using a low dosage of a contrast agent that is enhanced by the AI, right, for visual interpretation by the radiologist. That's something that's cool, right? It's one of these things where instead of making the physician faster, we're changing how things are done. I think the other area where AI is super interesting is not just in making physicians faster, but actually making healthcare more available. So not everyone has access to a physician. So whether it's fast or not doesn't really make a difference to them. Where I'm pretty excited is seeing these AI algorithms get deployed in countries that otherwise don't have access to the kind of high-class physicians or interpretation that we might have in more developed countries.
Great, thanks, Josh. And that's a fantastic segue into sort of opening up the discussion. I'd just like to invite any of our panelists who have views to maybe say a little bit about how AI is improving health equality and accessibility, who's benefiting, who's been left out, how does AI remove obstacles to access? So I'll open it up for any of our panelists that would like to address that as a subject. Afshin.
If I talk about pathology, one of the things that we've seen, as I said, we're a technology company, we're not a healthcare organization, but the average age of a pathologist in the UK is 55. And what we're saying is the stats, maybe within the next 3 or 4 years, the pathologist population is going to be retiring. So that's going to be one challenge. And then the number of entrants into the pathology health market is fairly limited. So one of the areas when you talk about accessibility is around providing data in a secure environment which allows pathologists, irrespective of geography, to be able to pass comment on data remotely. So if you can be sitting in Birmingham and passing comment on someone down in Cornwall, that would be a clear benefit. So it's sharing of that data in a structured, secure manner. We would have all seen the press over the last 6 weeks where AWS and Microsoft Azure had outages and it caused a disruption in the market. So what we need to do is we need to make sure that those dependencies and those risks are managed through approaches that we adopt through critical national infrastructure to make sure the resilience exists. The second part of that is around the storing of that data. So coming back to what Dr. Anushka said, is having the ability and the governance and the policies to permit people to share that data. Because if the data isn't there, then you can't really utilize it. And I guess the other aspect is protecting that data. How do you protect that data? How do you manage that data in a secure environment? And lastly, what I would say is around AI. What we've seen is we've seen the green agenda coming into as well. So one of the areas that we've been talking about is what you don't want to be doing is you don't want to be transiting data multiple times into different environments. If you can bring the AI capability that Joshua talked about, multiple AI applications into a data center where the data sits with the GPU farms right next to it, it'll support the green agenda. It'll support the view that data is not transited in a manner which creates insecurity. And also building resilient platforms gives you the assurance that effectively if a system goes down, you're not beholden to purely technology, which could have adverse effect on health.
Anushka, thanks, Afshin.
Thanks, Ashwin, and support you and totally believe you there. And I think, having partners like yourselves that are technology partners can help healthcare solve problems quicker than just clinicians like myself. So it's very important to have that collaboration. I want to bring this to light in a really simple way in that a lot of patients we see in the UK health system don't have English as a first language. and or don't have the literacy of English in the way that would make a medical consultation easy to understand and synthesize. And myself, I can say this as a doctor, we speak in jargon, and that makes it really, really difficult for the patient to feel comfortable, to feel psychologically safe, to answer questions, and to be able to actually truly engage in their health. But we know a patient that is more engaged in their health and their health decisions will have ultimately better health outcomes and better adherence to treatment. So the system has this conundrum to solve for. And this is where AI can help. In patient consultations, having an AI scribe to assist the doctor so the doctor can read more of the behavioral signs with the patient, or make the patient feel more comfortable, or provide better empathy. Whereas currently they're focusing on administration tasks, they're diverting what the true top of the license work is, being a doctor and being able to diagnose through the understanding the patient. Because ultimately the patient actually will be able to tell you a lot if you give them the opportunity to. Secondly, we have a language problem in this country whereby a lot of our doctors speak English, a lot of our patients don't, particularly in regions like yourself, in Leeds. I'm from Bolton originally, and Bolton has a very diverse community, sort of areas in London. Having a patient feel comfortable in that environment and being able to have a translator that is there, that is present, even if it is AI, will reassure the patient and get a better outcome, and then a better result for both the patient and the doctor in terms of time efficiency. So that's the patient. In terms of the system, I think Afshin and others have alluded to this, creating efficiencies for the doctor, taking away the administrative burden, whether it's note-taking like AI scribes, or whether it is, automating and reminding. When I was a junior doctor, I think now they're called resident doctors, on the ward, we had to go through a patient list and tick off how many bloods we've done and what, and print labels. And I mean, if that was all done by AI today, I would save a lot of time, and I could dedicate that time to learning rather than performing a task that wasn't actually needed to be performed by a human. So you see AI being used in those environments, being able to prompt, navigate, nudge the physician into a better space to make the right decision. And then the final piece for the health system. We hire lots and lots of people, whether it's the US or here or any other health system, to do things like scheduling, billing, invoicing. And the health system in the UK hemorrhages money because they aren't able to recoup, for example, invoices and payments from either businesses they're working with, suppliers they've hired, and or people visiting this country who are medical tourists. And if we could automate those processes, the health system would again become more efficient and more effective. And then the money within the health system, whichever health system it is, could be dedicated to where it should be, which is clinical-facing innovation and or clinical-facing environments.
Thanks, Anushka. Sunil.
Yeah, totally echo Anushka. I think when it comes to access and equity, it's broad. It's quite a lot of, apart from, linguistic barriers, there is geographical barrier as well, there is economic barrier as well. We know the fundings are very different as we move from south to north of the country, particularly in UK. I don't know, Joshua, how that is in US, but there is a lot of obstacles, I feel, in terms of healthcare access. If we assume that data is good and good quality, I think if the AI is being used to actually signpost or rationalize support, I'm more for it. So, for example, missed appointments at the moment within England, almost 1 in 10 people don't turn up for that appointment. So that's a big loss of efficiency in the system. And if you look at the individuals who are not coming, they are generally speaking from social deprivation and poverty. So the access is a problem. And if you use AI to identify or predict who that would be in a way to then enable support system, I'm all for it. Rather than labeling some people and doing differently, if the AI is going to allow us that limited resource to be used so then we can support those individuals, then that's actually a great use of AI. Of course, the data and all the attributes that we're talking, that completeness is the key thing. For example, language, there is no documentation what language need is of that patient. For example, ethnicity, only 20% of them might be accurate. So we just have to be careful. As long as we are not using AI to exclude a treatment, I'm fine. I suppose the other thing when it comes to geography, as you go in the north of the country, the hospitals and the rural health becomes a really important parameters. And we got some really fantastic tools within Yorkshire where we're using app to manage like virtual wards, the COPD patients or cancer patients through very simple AI, nothing fanciful AI, but a simple tool that can actually, again, coming back to linking that with resource saving. We can't just keep adding more and more and more that needs money and more infrastructure. I think any AI or any infrastructure that is being proposed need to save something of that equivalent. So we can then be in a sustainable growth, actually, because that's really important when it comes to technologies like AI. It needs to work in real life, in patient pathway, and it should release resource, not additional thing. I'm afraid that's not going to work in a resource scarce system.
Thanks, Sunil. Josh, some great examples there from the north of England. A perspective from the US, is it that different?
I guess I could add my very American perspective, but I won't poke too much fun at our healthcare system here. Interestingly enough, along with translation, a lot of what I've seen is simplification, right? There's products out there like Scanslated would be a good example. When you tell a patient the word epidural hemorrhage, right? Not even the folks that do speak English quite fluently might not know what that means, might not know what the impact is, right, for them as a patient. So there's also the idea that a physician can speak in the language of being a physician, right? But the patient can hear what it means for them in, call it plain English, right? Or in the case that it's translated, plain whatever language. So taking it from epidural hemorrhage to saying, okay, look, we might need to do this kind of treatment, et cetera. This is what an epidural hemorrhage is, and giving that kind of explanation. And so again, there's a ton of products out there that do this kind of things. Scanslated would be an example of one. And then to Dr. Daga's point, I see a lot of, call it prioritization of limited resources. I think one of the most successful applications of AI that I've seen, it's not even in diagnosis, it's not even in speeding up a physician, it's actually in triage, right? So let's say you have 10,000 CT scans that a radiologist needs to review. Moving the ones that are higher likelihood to have a stroke to the top of the stack is one of the most important things we can do, right? And we've seen that be very significant. It's not a, call it replace or even change what the physician's doing. It just orders what they're doing their work in. And in a thing like stroke, where time is brain, so to speak, that does have a very, very meaningful impact on patients. So, yeah.
Thanks, Josh. I think that discussion illustrated quite how AI has the ability to remove lots of those barriers to access. Can I just ask, where are the risks and the barriers to adoption and making sure that some of these AI applications are rolled out as comprehensively and as promptly as possible? Where are there barriers to that? Where are there things that are maybe holding that back a little bit? Josh?
Yeah, so one of the more interesting things I see developing in the market is there used to be a bunch of point solutions, right? So you'd have an AI that would detect hemorrhage in a CT scan. You'd have a completely separate AI that would, find kidney stones. A third AI that would go ahead and look at lung health. And each of these would require its own contract and its own kind of security and integration. What we're now starting to see as the models get bigger and bigger, and we have foundation models, you now have a single model that can diagnose multiple things. And so I think that is going to rapidly accelerate adoption of AI, especially in the space of radiology, in the sense that now a hospital can integrate one model, go through one security review, have one contract, but have that AI diagnose all modes of disease, right? And I think we'll eventually reach a future, call it in 5 or even 10 years, where each hospital is employing at least a single model in radiology, or a single model within pathology, whatever it might be, rather than these collections of models, which ultimately end up providing a lot of burden onto the hospital system.
Thanks, Josh. Sunil?
Yeah, I think, well, apart from, Joshua, as you mentioned, the agility and interoperability, I think for me, the biggest thing is the value proposition. When an AI technology is being proposed, at the moment, the biggest barrier is it's not being worked out in real life setting in UK or in NHS. That's my biggest thing that I notice. And then the whole regulatory aspect and getting, if it needs, for example, nice technology appraisal, we are sort of stuck few years in the pipeline. And by then, the technology space moves so fast that you got a version number 7 where you're still on version number 1. And of course, the AI at the moment, we do not allow an automated intelligence, sort of an autonomous one. We want a fixed algorithm that can be implemented. So that time lag of a development and approval, and then the industry moving faster, there's a lot more things coming too, which is nice. But in a way, I don't think we are matching the pace, I'm afraid. And that's a biggest barrier for me as a system level.
Thanks, Sunil. Anushka, I think you wanted to come in to talk about risks and barriers.
Yeah, just to build on the both Josh and Sunil's comments so far, I think going back to that concept of trust, and as Sunil, you touched on it briefly there, it's trust in the system to launch these. And if you think about real up and coming, the most exciting AI is built in black box environments. Although a lot of these startups that are doing this are jumping through the hurdles, whether it's HIPAA or GDPR compliance, whether it's class 1 or 2 medical device approval, the ISOs, the cybersecurity, so on and so forth, there is still a fundamental issue with trust. And the people procuring the solutions aren't necessarily able and willing to trust. I know a lot of businesses doing some great stuff in health tech and health AI, but they aren't able to pass the due diligence process required of NHS trusts to do so, whether it's asking for a 5-year cash flow or, financial security of a business, so on and so forth. So the kind of crux of the innovation isn't actually getting into ground level. And if it is, it's in the pilot stage. And again, there's, that leads to the collapse of businesses because they're not being funded in the right way and not able to catalyze on their innovation. I think there's that one piece. I think the second piece really is around education. Because myself, I can go to my peers. I left practicing medicine over 11 and a half years ago, even before the term AI, as Sunil alluded to, was even thrown around. And I was working in data science and in population health from the day I left. I can still talk to my peers who went to medical school with me and talk to them about AI. And the majority of them don't even use ChatGPT every day because they don't really know what it is. It's not embedded in their workflows. They haven't been taught about it. They haven't been educated on it. And I think that's the key challenge we're facing is that, we say workers, whether they're doctors, nurses, social care workers, wherever they are in the system, we say they have the most time-poor lifestyles. We also say that they are poorly remunerated for the role they do. And then they've got work-life balance pressures and, they, bless them, have the most amount of resilience, but where do they get the time to learn about these things? Where is the education happening? There was a classic news article recently how Gemini has been unleashed on an NHS trust and none of the doctors have had training. And how unsafe is that? Because then, there's no real guardrails around it. And I think that's the challenge we're at. We're at this trust challenge, but the system needs to invest in educating across the board, not only the positives, but the negatives, put in place the guardrails, and then allow implementation of AI and experimentation, knowing that it's a measurable impact we're looking for, and being able to allow those experiments to happen, whether it is black box algorithms or not, I think is the missing piece, the final third part of that triad.
Thanks, Anushka. That is really sobering, the fact that education and understanding is so lacking in so many professionals in the sector.
Just to take that on board, I was in a room recently of I would say, well, I'd say I'm a millennial, so whatever generation, the 2-3 generations that came after me. I was in a room recently and I asked them to describe AI in a sentence and none of them could. And then you start telling people that AI is actually just data and models built on patterns, and all of a sudden you break even those baseline blocks down, and people turn around and go, oh my God, I didn't know that. I didn't know AI was data. I thought it was something cooler. And I think that's, that anecdotal story tells you exactly where we are in the world with relation to AI. You've got your early adopters, but you've got a huge area under the curve of people not actually truly knowing what it is and what, curates it.
Yeah, thanks, Anushka. I'm going to bring in Afshin and then I'll come back to you, Josh, if that's okay. Afshin.
Thank you, Alastair. I think we have a perfect storm brewing. And what I would say is, if you look at what's happening, if I just focus in the UK, you've got the cyber threat, which is a bigger issue around the threat of security and cyber evolving. And that is sort of with integration of systems, applications is a concern. Then what you have is you've got the restructuring of the NHS. Dr. Sunil will know this, with NHS England sort of not ceasing to exist, becoming Department of Health and Social Care. You've got the restructuring of the ICBs taking place in the UK. And then the third point that Dr. Anushka mentioned is around the capability, understanding of use of technology in an intelligent way around training and development and understanding. So if you think about it, if you mix all of that together, it becomes a very challenging environment. And the question is, how can you unpick this and make it very simple to ensure that the adoption isn't seen as a risk, but it's seen as an opportunity? And I think that's what I would really focus on. So I think the investing in people and the training and development and cultural alignment and cultural education is quite important. The last point I would say is that even as a service provider, when we're entering this space, we assume that we have the skills and the capabilities already available. As service providers, we find the capabilities around adopting AI and knowledge in the market is very sparse. And sort of the capability of bringing that into life is something which requires investment as well, let alone the consumers of that service being clinicians. So the technology gap and capability is also something which needs addressing. But absolutely, there's an opportunity, and it's really simplifying the message and ensuring that people understand how, where, and in what context they can use it in a safe manner, and removing the dependencies to enable success.
Thanks, Afshin. Josh?
I think I share Dr. Patchava's experience as a millennial, so totally understood there. I agree. I mean, a lot of what we're seeing is people don't understand what AI is, but also calling things that aren't AI, right? I think that term has started to become very overused. When you talk about basic statistics, like a linear regression, people are starting to refer to those kinds of things as AI, right? Rather than these kind of trusted mathematical tools. What we always forget is that AI can hallucinate, it can make mistakes, but we don't want to start labeling things that aren't AI, because then they start actually degrading in trust sometimes. And so it's interesting to see how all statistics, all machine learning, all models are starting to be called AI when most of them aren't, right?
Sunil?
I think I might just add another aspect as a barrier. Who is responsible for an error? It's a big elephant in the room, especially if you're going to roll out AI decision support tool. It's a support, but actually there is a risk that people will just accept what's come there with not using their own intellectual. That's the biggest risk, actually. And the second thing is, losing the skills, because AI is taking simple tasks, repetitive tasks. What that means is, as a human, as a healthcare worker, we are not actually spending many time. I personally feel that even if the AI tools are implemented in X-ray or mammogram, 20% of time, the humans should be spending the time so they don't lose that valuable skill that's been achieved through the evolution. If we suddenly move everything to the computer, that is a real worry a lot of healthcare professionals have. Of course, losing job is another thing, which is always there. But I think the autonomy going away, blindly following the AI, perhaps Anushka, from your legal side, you might have a comment. Who is responsible for errors? And that's the biggest barrier actually. Everything has been blamed on doctors for the wider workforce. And then are we going to be blamed even more if the AI is happening because we are sort of oversight as a consultant responsible in that department? That needs to be addressed.
Thanks, Sunil. Yeah, a big question there. I'm going to sort of push the discussion towards a conclusion, but before I do, and to do that, I'm going to go around the panel again for some final remarks. Is there anything that we haven't covered that anybody would like to address? In that case, going around the panel, starting with you, sort of Afshin, can you say a few words just in conclusion about where the focus should be in the future and what your hopes are for AI in the future in terms of impact?
I would say the pace of change is moving so quickly that it's not going to take years. I think the pace is there. I think what we need to do, this is from my profession's perspective, this is a technologist who can enable support for experts in the field, is to ensure that what we do is we remove any risks or perceived risks around sharing data, accessing data, pulling that data, and governing that data. And that's all we can do. And I think if we can bring that change and present viable options to act as support tools, as Dr. Sunil said, not determining factors, because hallucination is a big factor, I'm determined that we will, on balance, see net benefit in the use of AI as we deliver healthcare, because the traditional models of funding, the traditional methods of working in the UK in support of the NHS, I don't think is feasible. We're seeing that at the moment. Constantly, the budgets are being reviewed and it's still under pressure. So we need to think about this radically, and technology, I think, can be an enabler, but it needs to be done in a safe, government manner. I do accept that. And I think the partnership with industry and the public sector and the health service can maybe remove some of those challenges.
Thanks, Afshin. Sunil, your thoughts on where the focus should be in the future and your hopes for the future?
Well, I really feel that training AI should be part of the curriculum right from the beginning. We still get taught anatomy and pharmacology and whatnot with very little application when we are becoming a doctor, whereas AI is a part of it. I really feel that needs to be a major subject moving, well, it should be now, but moving future, every medical student, nursing student, pharmacological student, they should have that as a curriculum so they understand and feel comfortable and confident of using that. But also a space where they can write small algorithm. It doesn't need to be all the techie guys doing all the technology things, simple algorithm that they can feel confident and can implement in their day-to-day work. We don't have to depend all the time on industry. We need to have a space in our EPR or patients, where we could actually work on simple things. And of course, all the complex things we can keep to our brilliant technology presence. My hope really is that it's going to enable a lot of savings, a lot of releasing of time that we can then spend back to the direct patient care. That's where my real hope is. But of course, we need to safeguard all the legal side of things and the confidence side of things.
Thanks, Sunil. Josh, same question to you.
I think echoing what Afshin said, we have this amazing opportunity with AI. At the end of the day, if we don't make the data available to train that AI, you end up actually exacerbating healthcare disparity, right? So if you build an AI only on people that look like me, then it's only going to work for people like me, right? And so really, if we want to prevent that future of exacerbating healthcare AI, it starts with making diverse data available to these folks that are building AI. And that's the place where we have to start. If we do that successfully, AI will change healthcare for the better in a way that it hasn't been changed in many years. If we don't do that, we actually run the risk of going backwards. And I think a lot of people don't think about that context. So.
Thanks, Josh. And Anushka, looking towards the future.
So I think building AI for AI's sake, or building anything for the sake of saying you're building it, is a phenomenon we're stuck in right now. And I'd say 90 to 95% of the businesses building right now actually don't start with the why. They don't have real world evidence of what they're trying to solve for. This becoming an entrepreneur or a founder is now the sexy, cool thing to do. And a lot of people are trying. And I don't want to shun or stop experimentation and innovation, but there's little point building unless you know why you're building. And for me, there's three areas. One, whether it's in the UK or globally, the healthcare workforce is diminishing. You can change that by making the environment, a better place for these workers. But at the end of the day, it's diminishing at a rate that we need to do something about it. So allowing the healthcare workforce to function at that concept of top of their license, what they're trained to do, and Sunil alluded to this when he was talking about his training and education piece, is the most important. And that's where AI can support, whether it's in the education, whether it's in decision support, whether it's in remote monitoring, whether it's augmenting the existing workforce through capability, etc. The second big problem I see in healthcare today is the front door is too wide open. Most health systems have similar to the UK, like a primary care triage model, but there's not enough healthcare workers in that primary care triage model. So patients are getting diagnosed later, and that means health outcomes are worse. And why are we trying to fix the health system? Because we believe the population is getting unhealthy. We owe the population better than what they get today, whether it's cancer or anything else. So how do we allow diagnosis to happen quicker? Yes, Signpost, like the business I work for, was one of the solutions. But equally, Josh talked about it, chatbots, symptom triage checkers, risk stratification tools, being able to prioritize those that need it to the right environment. And we've lost this need to have everything in the hospital. We're starting to see remote patient monitoring. We're starting to see clinical environments be moved back to the community. We're starting to see hospital at home scenarios, whether it's chemotherapy or otherwise. Let's continue on that journey and use AI to support that. One of the biggest and best British businesses today in the success stories in the space is Zero Care. They took social work out of social care and they put emerging technology and tools, including AI, not just AI, into that environment. We're able to train a large workforce and able to support people in the community much better than other systems were. And that's where I see the big value. And then the third piece is doctors mess up a lot, but more than doctors messing up is that treatments, like Josh alluded to, are not personalized. And if our AI models are all white Caucasian male, then we're not going to ever get to a point where we're personalizing treatment, which means there's going to be a lot of waste in the system. Waste of treatments, waste of modalities, waste of time. Imagine a cancer patient wanting personalized treatment, not being able to get it because the model is based on white male Caucasian. So I think we need to open up the data, open up the environment so people can share more, the data is more fluid and people can share more reliably. And then critically for me, use that to drive personalization. So it's not a one size fits all and there's less wastage in the system, which will help, again, the issue of not enough money to serve the population. And I think those three levels for me are the most important.
Thank you, Anushka. And on behalf of Health Tech World, thank you to all of our panelists for sharing their insight today. It's made for a compelling and I think important discussion. For all those that are watching, please share this as widely as possible. It really does deserve to be seen by as many people as possible. So thanks once again to our panelists, and for all those watching, enjoy the rest of your day. Thank you.